Hello, I'm Sanaa Said. I'm a physician based in Zanzibar and I work at the State University of Zanzibar. I'm also a PhD candidate at the University of Bergen, working with the Bergen Centre for Ethics and Priority Settings in Health. Now, Zanzibar is an archipelago of islands off the coast of East Africa, and it's a union of two countries, and it's part of Tanzania. It has a population of 1.9 million people. And the healthcare structure is that each person is within 5 kilometers of a health facility. But the health facilities start from the primary health facilities to the district and then to the referral hospital. I mostly work with patients with inflammatory joint diseases, commonly rheumatoid arthritis. And it's an autoimmune disease that mostly affects the joints, although it can affect other parts of the body. And rheumatoid arthritis affects women more than men. And when it's untreated, it causes a lot of damage to the hands and joints. It also causes a decreased quality of life and eventually can cause a lot of disability and permanent damage. Now, the hospital where I work in Zanzibar has been there since 1896, but it has never had a rheumatology clinic since it was started. But however, we were seeing a lot of arthritis patients at the medical clinic, and there was no medication available for them within the hospital pharmacy. Most of the patients would come to hospital quite late. Some of them would come and the damage had already occurred because many of them did not know what the disease was, so they would seek alternative medicine. That is, they would see traditional healers, they would go for spiritual therapy, and so on. So by the time they came to us, a lot of damage had already occurred to their joints. Now, we set out to establish a clinic at the referral hospital so that we could care for these patients, provide standardized care for them in keeping with international guidelines. And we had to do this in various ways. Knowledge on rheumatological diseases is quite low, not only in the community, but also among healthcare providers. So we set out to educate doctors working at peripheral facilities on how to detect and refer patients with rheumatoid arthritis. And this took place over sessions in collaboration with the NCD unit at the Ministry of Health. But we also reached out to a local NGO called the Zanzibar Outreach Program to help us fund the creation of a patient information leaflet on rheumatoid arthritis, which we use to distribute to patients within the hospital and also when outreach services are undertaken. The leaflets talk about rheumatoid arthritis in Swahili, and we've used pictures within the leaflet from patients themselves. So sometimes patients get really excited when they look at the pamphlet and they say, is that my foot or is that my hand? Or patients will say, that really looks like my hand, and it became quite relatable to the patients. The other thing we did, because we also did encounter some quite difficult to manage cases, we had once a month online teaching, clinical-based teaching, where we share cases of difficult to manage cases. And we invited rheumatologists from other facilities, as well as other healthcare providers at other facilities who have rheumatology cases they would like to share. And these meetings are guided by what we see and what we find difficult, but they're chaired by Dr. Clive Kelly, who is based at Newcastle upon Tyne Hospital in the UK. But occasionally we do have attendance from the rheumatologist based here in Bergen, Björg Tilde, at the University of Bergen and Haukeland University Hospital. The other thing that happened is that in order to sort of cultivate this interest and to create knowledge, we had hands-on training. Professor Clive was kind enough to fly down to Zanzibar, and we had hands-on training on how to examine musculoskeletal system, and there was some teaching for the doctors how to do intra-articular injections, and also how to manage the difficult cases that we saw together with him in the clinic. The other thing we did is we involved stakeholders, because you cannot change the status of things without involving people, decision makers and policy makers. So we set out to have a meeting with the Ministry of Health, and we met with the officials at the ministry to be able to tell them about rheumatoid arthritis and what we had been seeing. On the picture right next to me, we have Ms. Remla Shirima, who is a physiotherapist based in a different part of Tanzania, but she volunteered to come during the education sessions to teach the physiotherapists how to manage patients with musculoskeletal disorders. Next to her is the Assistant Minister of Health, and next to him is the Minister of Health of Zanzibar. We also have next to him, that is Professor Clive Kelly from Newcastle, the UK, and we have a physician based at Nazim Moja Hospital, that is Ahlam Amur. And together we met with the ministry, and they agreed to prioritize rheumatoid arthritis care in Zanzibar. The other thing that we did is we tried to improve care for patients. We did have joint injections that we performed, and as you can see in our clinic, these injections sometimes have to be done without ultrasound guidance, so it's very clinical, and you can see Professor Björk-Tilde standing next to me. We also set out to include rheumatoid arthritis care within the standard treatment guidelines of Zanzibar, and we took examples from international guidelines where patients are provided with what we call disease-modifying anti-rheumatic drugs in order to halt the progression of their disease. We also strived to make sure that medication was available, and this entailed performing a cost-effective analysis so that we could convince the government that medication for rheumatoid arthritis was important. So in settings where resources are limited, you have a lot of competing interests in terms of healthcare investment. The ministry has to decide where they would spend the money most appropriately. And one of the things that is used to make these decisions is a cost-effective analysis. And we performed this analysis in order to convince the government, or in order to determine which of the treatment packages would be cost-effective to offer in Zanzibar. And we looked at different treatment options. We looked at different combinations of drugs. Some of these were the basic drugs like methotrexate, and others such as sulfasalazine or hydroxychloroquine. But we also looked at combinations that involved drugs that are used, the newer drugs that are used in other settings as well in the West. Now, in Zanzibar, the cost-effective option would be methotrexate as a standalone therapy if the government were to invest $282 per quality adjusted life year gained. That is per quali gained. However, if the government were to increase investment to $1,136 per quali, then the cost-effective option would be methotrexate plus a biologic or a targeted synthetic DMARD, whichever is cheapest. And even if the government were to double that investment, then the cost-effective option would not change. So we've also tried to look at, as part of the PhD, we've tried to look at what are patients' outcomes once we follow them up. Once they come to clinic and we start them on therapy, what do they do? How do they perform at follow-up? And we found that even with basic medication, that is methotrexate and other simpler drugs, patients do improve at 1 year of follow-up. That is, their quality of life has improved, but also their disease activity is much lower. We also separately looked at health-related quality of life in patients with rheumatoid arthritis, and we found that at baseline, it was quite low. Patients had difficulty in, some of them had difficulty in mobility, but a lot of them complained of pain and discomfort. And once you put them on medication, they do improve. And this improvement was seen to be significant, particularly for patients whose disease activity was quite low. As part of the PhD research, we also found that methotrexate is the cost-effective option within our setting. And overall, what we have seen is that when you educate people about rheumatoid arthritis and to refer patients, you end up getting a lot of other rheumatology patients. So apart from rheumatoid arthritis patients that we see in clinic, we've also had several other rheumatological disorders, such as lupus. We've also had rarer cases of things like chronic recurrent multifocal osteomyelitis, which is quite rare in the rheumatology world. So the clinic has grown in a sense, and we don't only cater to patients with rheumatoid arthritis, but we have seen multiple patients with other rheumatological disorders. So in conclusion, we have been able to set up a clinic in a setting where we have no rheumatology expert. And we've done this using several methods, that is educating the healthcare personnel, involving rheumatologists from other centers in a low-cost way by setting up the Zoom meetings, hands-on training for the doctors within the clinic. And we found that our model is applicable even in other resource-limited settings in order to expand care for patients. And this is patients not just with rheumatoid arthritis, but many other rheumatology disorders.